thank you for deciding to spend your time with us instead of going to other events or having a well-deserved break. This is a special subject webinar just for children immunization. We covered a little bit of it in April as part of our course webinar, but today we are going more into depth and we are presenting more CEG support tools. And I'm very pleased to see a good mixture of clinical and what we call managerial or admin team, which is ideal because I can never stress enough how important it is for both teams to work together when it comes to children immunization. You really need that partnership of administration and clinical knowledge. And thanks to NEOM in particular for turning up in great numbers. Before we get started, I want to acknowledge the very difficult job that London practices and North East London practice in particular have when it comes to vaccinations and immunizations. We can't really help with all these systemic issues such as anti-vax sentiments and high rates of population mobility, population born outside the UK, etc., etc. We are all very aware that these are difficulties that you have to deal with day to day. But that's not the focus of today. Today we're trying to focus on just very concrete concepts and steps that you can take. So what we are actually covering is things like what is cover, what's happening with COV, items of service, core standards, catch-up, MMR catch-up vaccination, and a couple of other bits and pieces. So what is cover? Let's just get this out of the way first, because it's something that comes up all the time, but there is a lot of misunderstandings about what it actually is. Cover stands for cover of vaccination evaluated rapidly, which sounds a bit funny nowadays because it's not exactly rapid. But when it started 16 years ago in 2005, it was very rapid because obviously the way of capturing data in those days was not as efficient as it is today nowadays. You can still, if you are curious, go back to the archives if you Google it and find the data, which of course has got a lot of holes in it. It's a standard measure of vaccine uptake, approximate measure of protection, basically, and it gets collated through patient identifiable data that Discovery extracts out of North East London practices, clinical systems, and sends to CHIS, the Child Health Information Services, who then put it together and publish it for everybody. CEG also publishes this data, but it's not. It's informal, if you want. It's just for your use. It's not. It doesn't inform the data you actually see on publicly. And the reason we do it is because we can do it faster than CHIS can do it. The problem with cover is that it does not reflect recent intervention or events. So, for example, when COVID happened, there was a big impact on vaccination rates, but that didn't reflect in cover till 9 months later. Equally, if you start a new wonderful system of call recall, or you employ more nursing staff or whatever, you do something really, really good, that's not going to be reflected again for a number of months. And that is because the cohorts are looking backwards. So when you, and we'll explain that a little bit later with examples. So it shouldn't be used for basic call and recall, is not related to payment, and it does not count the number of vaccines that you have been given. So the cohorts change quarterly, so it's about children becoming a certain age. There are 3 cohorts: children becoming 1, children becoming 2, and children becoming 5. So as you can see, there is nothing about, for example, children who were born 3 months ago. And it covers all the routine scheduled vaccinations that you know of. Now, we'll park that for a minute and go to other issues. What is going on with COV? people are quite scared, quite rightly, about when they look at their new cohort of vaccination indicators, because they see very little achievement there. It is quite scary, and you're wondering, why is this? I always did quite well with vaccinations. What is going on now? There are several reasons why you might be having problems with this. One is that the targets are extremely high. We're talking about 90 to 95%, which is very, very high. Another reason is that something called timeliness has been included in these targets. Timeliness is something very good clinically, because the closer you give the vaccination to the right age, the more protected the child is. However, we would have expected this to be introduced a little bit more slowly, not immediately. But it is what it is. So what COF is doing is that it wants you to give the hexa, for example, by the age of 8 months, rather than before you might have been judged about whether you had given it by 12 months, for example. Or with the first MMR, you might often have been judged about whether you have given it by 24 months. Now in COF, you have to give it between 12 and 18 months. So that's quite significant. Another reason that you have trouble with COF is that there is no personal care adjustment, which is what exceptional reporting is called nowadays. So if people decline, that's not going to help you with your targets. If you've done 3 invitations, that's not going to help you with your targets. How in the way they would happen with, I don't know, with hypertensive, for example. Why is this? Because vaccinations are different. In vaccinations, you need something called herd immunity. So there is no excuse, if so to speak, if people don't want to have the vaccination. You still need to keep trying to convince them, because otherwise the whole population is not protected, basically. And finally, and more confusingly, you are very used to working with COF, and in the usual example of a list of hypertensive patients, you would have a search that looks at whether they have had, I don't know, a blood pressure taken in the last 12 months. And in the excluded list, you have the patients, the hypertensives, who have not had a blood pressure taken in the last 12 months. So, so you would use that excluded list and you would call them in. And that's how you are used to working with COF. Unfortunately, that doesn't work with vaccinations. With these vaccinations, you're not going to be able to use the excluded list. Why? Because it's going to contain a mixture of things. To understand that, you need to understand what's in the denominator cohort. So in the denominator, you have all the children who have become or will become a certain age during the financial year. So you will have, for example, all the children who will be 8 months old on the 30th of March, but they are not 8 months old yet. And you will also have the ones who became 8 months old in April this year. So that's a lot of children. And in the excluded list, you're going to have children who have already been vaccinated, but not by 8 months. Or you are going to have patients who have declined, of course. Or you're going to have patients you can still vaccinate, but it's too late to catch them before the 8 months. So you can still vaccinate them, but it's not going to help your target. And you might even have children who are not due the next jab. For example, someone who had their second hexa yesterday, they will still be in the excluded list, but they're not due for their third hexa yet. So it's, as you can see, it's quite complex, and you can't use the COF searches as you are used to doing, which is why we have published this, and hopefully you are receiving our e-bulletins and you know about this already. We have published these searches where we are trying to help you catch the patients before they just slip beyond the COF points. So this is not a call-recall system. This is just about trying to catch them before it's too late to get your COF points. A question: what would have happened if these indicators had been in place last year? Okay, so what we did is we edited the searches for this year. we changed the dates and all the rest of it, and we run them as if we had run them on the 1st of April 2021 to see what would have happened if these had been in place last year. And the answer about whether Nell would have got quof points last year is, well, really not really. For the first for VI001, 81% of practices will have received no payment whatsoever, and only 11 practices in the whole of Nell will have got full points. For the MMR indicator, the number 2 is even worse. 89% of Nell practices would have received no payment whatsoever, and only 6 practices would have got full points. We're talking about the whole of Nell. If we look at number 3, which is the preschool boosters, we don't even want to go there. I mean, if you look at it, we're looking at 5%, 37% at the most. Why is this? Well, we'll deal with that in the next slide. The problem with, again, if you have received our e-bulletins, you know about this already, is because NHS Digital have decided that a code that was used for the preschool booster across the board in most templates, not just ours but everybody's, has been discounted as not acceptable, which is the low dose diphtheria blah blah blah. So that code, it was used across the board, but now they've decided it is no longer any good. So what you are having to do is have to add the other one, the booster one, and that way your achievement for the third indicator will go up a bit. If you have any trouble with this, as usual, contact your local facilitator. Now, okay, sorry. Next slide. Items of service. So before you had you were paid through the DES at the end of the year. Now you're paid through quof and through items of service. So we've talked about quof already. Now we're talking about the items of service. In the past, you had to do manual uploads to OpenExeter in order for them to decide what you will be paid at the end of the year for the DES. Now the system has changed, and instead of you doing a manual upload, GPS is doing an automatic extraction into CQRS that counts all the vaccines that you've given in the month, and you are paid £10 per dose every month. So far, so good. That sounds quite simple, and they think in this way you are going to more practices are going to get paid than in the old way that the DES did it. Now the problem with this is that there is a provision for clawing back the money. So what the documents published in March 2020 say is that if you have less than 50% coverage, you will have to repay the whole money that you've been paid through items of service. If you reach 80% or more, you can keep all the money. And if you're in between, there is a sliding scale of clawing back your money. So this is a little bit worrying, and we wanted to help you to show you where you are exactly at the moment. But we could not do this, unfortunately, because they said they were going to publish the detailed methodology on how they're going to calculate this, but they haven't. And I've actually contacted NHS London myself to ask about this methodology, and it cannot be found. So at the moment, we do not know what this methodology is. So we don't know how they're going to count this 50–80%. And you might think, like, well, that's easy, isn't it? You just do whatever. Well, it's not easy, and I'm going to show you how not easy it is in the next slide. So this is this is an example. I've used Star Hamlet's data because it was more handy to me, but it doesn't matter. It's not about the data. It's about showing you how you can define different percentages in different cohorts and different targets in different ways and get different percentages. So so what I've done here is I've used the quarterly cover reports, which have got three different cohorts, but they all have a hexa in them, and then the yearly cover report with their three different targets, the QOF as it would have been last year at Q2, the QOF as it would have been at the the QOF as it is this year at Q2, the QOF as it would have been as end of year, the deaths as it would have been in Q2 if it still existed, and then I've made up a couple of more so that you can see how different the cohorts are. So you can see how the denominators are all different, some of them in their thousands, some of them in their 4,000s, but all really different. And then the percentages that can rate from a low of 70% to a high of 90%. So no, I can't tell you which definition NHS England are going to use to define the 50 and the 80%, unfortunately. If you want to ask me more about those different scenarios, I can go back to that later. This is just to remind you that you can see how many people have been extracted in your GP system. I know that some of you are aware of this, but I also know that some of you are not aware of it. So we'll send you a fact file to show you how to do this. You just go to Inquiry Manager, GPs and local report. You make sure that you show more buttons, because at the beginning it won't show, and then you will see all your GPS extractions, and you can choose one, use the View in Search Manager, and you can see exactly what numbers have been extracted and actually what patients have been extracted. So as I say, we will give you a fact file. If you are still struggling to follow the instructions, you can contact your local facilitator. Now, another important thing to remember: since April 2021, vaccinations are an essential service you cannot opt out of, and this comes with something called core standards. So the core standards are 5. One is that you must have a name lead for vaccination services, which is not necessarily, it doesn't necessarily have to be a clinician, but it's preferably if it is. And if it's not a clinician, they must work alongside with the clinician. The second one is about the provision of appointments. There must be sufficient number of appointments for all the vaccinations that are needed, and also there has to be a range of times. So you have to consider working parents, and it actually spells out that you have to consider working parents. And if your practice is too small to be able to offer these different ranges, you can work with your primary care network to offer a wider range of appointments across times and days of the week. The third standard is a set of standards about call and recall that we'll see in the next slide. Participation in agreed catch-up campaigns, which are going to see in another slide as well, and standards for record keeping, which is what you've always had to do, which is like record things like the batch number, record refusals of immunization, date of administration, etc., etc., etc. Just the typical stuff that everybody knows how to do. The call and recall standards specify that there has to be 3 approaches. So there's the initial call, which they say should be preferably with a pre-booked appointment and information on how to change it easily. Then a second invitation in case of no response, and a third contact that should be made by a healthcare professional by telephone or face-to-face. So it's not just a question of firing off just another text message. Then you have to really do a personalized approach. And also opportunistic. So they want flags in the system to remain as long as a patient is unvaccinated. And yes, they might have declined already, but the flags needs to remain there, and that's what the clinical system providers do. Now, CHIS has started to just very recently started to do the first and second invites by text message. which means that they're taking part of the burden from you. That would leave you with just the third personalized contact to do yourself. Although, of course, some practices will still prefer to do the 3 contacts themselves. When it comes to call and recall systems, everybody tends to have their own. Some of them are based on diary dates of birth or diary entries, things like that. We cannot provide different record systems for all sorts of, like, to cater for what everybody prefers. So we've got just the one, and one is based on the cover reports. And what it does is that it's a series of line reports that you can export into Excel, and where you find gaps, that's where you have to act. That's the simple teaching about it. If you do not know how to use this, please contact your local facilitator. And as a preview, we can tell you that we are working on a tool that will do all these sorting out Excel spreadsheets for you, and we are hoping to launch it at the end of January. And this is what we will look for. You can see that you've got, it looks a bit like the AF Apple tool or all the other cardiovascular disease tools that you've seen in the past. So you've got different age bands here, and then you can, for example, in this one, we've looked at who is at patients who are 8 weeks old, but not yet 12 weeks, so between 8 and 11 weeks, and who are 1 week overdue. And that's giving us Daffy Duck, Betty Boop, etc. And it's telling us that they are 1 week overdue. And then if you clicked on one of their names, like Betty Boop here, we get to another screen where you can see the whole record for Betty Boop in this case, including warning you that this patient has got the ethnicity missing and you need to do something about it, because that's a contractual requirement to have their ethnicity recorded. So I'm looking forward to launching that in the new year after Christmas, and you will be getting invitations for launch webinars and for different training events. Now, there are some schemes that are not routine, which are for example, the MMR Catch-up, the HB vaccination for infants born of positive mothers, and also a couple of very rare catch-up programs. I say rare because they don't really, they don't usually turn up for vaccination. It's just opportunistic. So the ones that we are really interested in are the first two, MMR and Hep B, because that's where you have to actively do something about them. For the MMR catch-up, it covers almost everybody, to be honest. Although people born like me before 1970 is not really recommended, because unless we're considered to be at a very high risk of exposure. But anyway, that's opportunistic. The one where you really have to take action, active action, even if that's a bit redundant, is for children who were aged 10 or 11 on the 1st of September or the preceding financial year. The catch-up terms say that you have to call and recall them, and that means 3 times. And of course, we've provided you with searches to see who these patients are. Neonatal hepatitis B vaccination. The first thing is, how do you know who these children are? Well, what we've done is that we've given you a search of women who are hepatitis B positive who have been pregnant in the last 2 years. So if you look at those ladies, you can have a look at their records, see if they've given birth, and see if their child is already registered and they have been marked as being at risk. So, and if they're not, please mark them as being at risk. So their children should have the code mother hepatitis B positive. And in that way, we can create the at-risk register of babies whose mothers were positive when they were born. And once you've done that, you can run the report, and you can see here to see whether they have had all their hepatitis B vaccinations, which are, there are six of them. It can be a little bit confusing to see if they've got their 6 vaccinations. The easiest way of doing it is using our template. As you can see, it's really simple. You can see when they are supposed to have what. So at birth, they will have had the first in the hospital, and it's very important that you record that, because otherwise you won't get paid for the subsequent doses which you are supposed to give them, which are the second Hep Junior at 4 weeks and the third Hep B Junior at 12 months old. And of course, they also receive the normal hexas. By the way, we've just updated our template completely. We've just checked all the coding in it, but also added the client and hesitancy page that you might find useful with a lot of resources. Just one more thing. Again, you would have read this in our bulletins, but just to remind you, just in case you missed it, what is SCID? SCID stands for Serious Combined Immunodeficiency, and it's a very rare disease, only 16 babies per year. But the reason you are hearing about it now is because there is a new pilot screening program where they've made this screening part of the newborn blood spot test that happens at 5 days. And if the patients are, if the babies are suspected of having SCID or have SCID, they should not have live vaccinations. So the first live vaccination that you would give them is the rotavirus. The first one would be BCG, but you don't give the BCG, that gets given somewhere else, so that's not your responsibility. The first one you do is rotavirus. So when they come for their 8-week vaccinations, which rotavirus is one of, you have to check their red book to make sure that there is a record of SCID not suspected or not done. So, for example, if the child is not covered by Great Ormond Street because they have come from another area where the pilot is not running, they would have not had the test done, and it's fine to give them the rotavirus. Cheese is working on data flows, but that is not ready yet. Just a final little list of things that you can do to help yourself, even though, as we said, the job is very difficult. That some simple things that you can do is using our children immunization template so that everything is recorded correctly, particularly when you get a child whose vaccination record started abroad or started in a practice from a different clinical system, because sometimes they don't translate very well. So that takes me to the second point. Make sure that you check and record vaccinations at registration point, and fill in any gaps or correct any errors that might be there. Ensure that these are correct. Always ask the parents to bring the red book to the appointments. Give out personalized vaccination schedules as soon as you can. Make sure that they know when the vaccinations are due, so that they can put reminders on their fridge door, for example. Give them information about the personal benefits of vaccination. This is something that has come out through research on COVID vaccine hesitancy, and it looks like patients respond better to personal gain rather than to social gain. So it's not enough to say, oh, well, you need to get your child vaccinated because that's going to protect all children in their age group. It's better to insist on what the benefits are going to be for your particular child. Always follow up DNAs promptly. Provide suitable appointments and make it very easy to book and to reschedule, because we all know we've all been in situations where it has been incredibly difficult to cancel an appointment, for example, and that can be a problem. Always use a good robust recall system, and collaborate not just, first of all, with your primary care networks, but also with local community leaders who know your community better than you do, and might be able to provide good role models, for example, and things like that. But I'm not going to go into detail with that. That's not the purpose of today's webinar. And I've been really fast, as fast as I could, and that takes me to the end. So now I am able to take questions.
I think Lacey's been answering quite a lot of them. Let me just check.